everybody. My name is Shia Ellenson. We're still over here. We are a motorized and custom wheelchair provider, specifically. And the reason why we're here today is to introduce ourselves, let you guys know what we provide, but also to kind of educate therapists on how many patients they have that can really benefit and qualify for custom motorized wheelchairs. And part of why we're doing this is because we're seeing a lot of patients in the home care side where the home care therapist is saying, now not going to you guys specifically, just in general, where the home care therapist says, well, I have a patient that had a stroke, came out of an acute care somewhere with a high back recliner, and they can't sit in their chair, they're basically bedbound, they're not getting out of their bed, they're basically, all that area that we're trying to work on them, they have the wrong equipment. Can we fix it or not? So instead of trying to upgrade it once they're out there, let's see if we can go to when they come into acute care, and they're going to be going home, let's get them the first up from the get-go. So part of what we're doing here is, and the challenge, and the reason why the subacutes in general are not giving out motorized chairs, because it takes a lot of work on the therapist side, and you guys don't have time to write long letters of medical necessity. By the time you finish your letters, the patient's ready to be discharged. You may have had experience where a patient's been home for 3 months, and then a provider reached out to you and said, how your letter denied because you have the right diagnosis in there, please modify it again, and you have your own caseload already. You don't have time for that. What we were able to do with our process is really simplify the process, take it from taking a patient to get a motorized chair where the industry average takes still a year to get a motorized chair. We're able to do it in 30 to 45 days. And the reason we're able to do that is because when we come in, a wheelchair specialist will meet with you and your patient while you're treating your patient. So if your patient's on the schedule that day for 10 o'clock, we'll come in at 10 o'clock while you're treating your patient. We'll go through the entire assessment with you, your entire justification, all that work will get done during therapy. While you're being compensated and working with your patient, you don't have to know all the aspects of the chair. We'll walk you through everything. We'll walk you through why the patient would qualify, what he benefits from it, why the insurance wants it benefited, what the insurance wants it, how they want it to be justified, what wording the insurance is looking for, all that type of stuff. We'll take care of that for you during therapy. So with that process in play, if you have a patient that you know is going home in the next few weeks, you give us a call, we come out, we meet with your patient, your job is done, the patient gets what they need. So what we did here is we gave out these eligibility guides. That's right, passed out before. Just try to give you an idea of what sort of patients can really benefit from more than just an off-the-shelf wheelchair. It's a two-sided eligibility guide. One side it has diagnoses. Now, it's not diagnosis-driven, meaning your patient is not required to have a diagnosis to be eligible for a motorized wheelchair. However, with these diagnoses, they may be more prone to requiring it or benefiting it. So we just put these diagnoses here that this is a very high popular demand for patients with, quad, paraplegic, ALS, MS, Parkinson's, muscular dystrophy, your stroke patients, spinal cord injury, CP or post polio. It's not an all-inclusive diagnosis. These are the more popular diagnoses where patients that would then require power chair. However, if you flip the card over on the back, we have the 4 P's here: propel, position, pressure, and posture. If any of your patients are having a challenge with either one of these 4, the odds are they are not going to get what they need, an off-the-shelf product, and we can probably upgrade them to a better manual chair or put them in an independent mobility. So if your patient has a hard time propelling, and by propelling we mean like you have the tug test for ambulation. How is it functional mobility? How fast can they propel? If the patient can physically get 10 feet, but they're not going to go to the bathroom because it's too far and it's too taxing for them, they shouldn't be in a manual wheelchair. Because it's physically getting there in a functional manner, doing their ADLs in a manual chair, if you don't have the strength for it, put them in a power chair. Position, if they require more positioning, are they sliding out of their chair, they're leaning over to the right? Pressure, does your patient have any risk for developing pressure ulcers? If your patient's not weight shifting effectively, if they're rocking, but if they need help transferring out of the chair, they need help to fully offload their bottom, the odds are if they can go back home and they're sitting in a manual chair that's basically a hammock and they're sitting in that chair for a few hours a day, they're going to break down. So you want to avoid that before you sit home with a regular chair. Give us a call, see what we can do for them for pressure management. Then posture as well. If you have a patient with poor core strength, so they don't have the strength to sit. I mean, anybody ever sat in a manual wheelchair here and tried to propel with their shoulders? You're sitting in a hammock. So somebody with good core strength is going to sit like this because you're not getting support properly. So somebody with impaired trunk control, they're going to slide right out of that chair. And that's kind of what we're trying to do, is really provide these patients with a much better positioning component, really increase their seating tolerance, increase their ability to be in a wheelchair, increase their ability to be out of bed and really, get on with their lives and be as active as they can. Another little feature I wanted to mention about, a lot of patients know they have a patient that got a chair a year and a half ago, it looks custom, might be a motorized chair, and they know they have to wait 5 years. There's this 5-year rule where you have to wait 5 years for a new chair. The rule of 5 years means you cannot get the exact same chair for less than 5 years. But if the patient's chair is not medically appropriate for based on these reasons, we can always upgrade them prior. Make sense? So if your patient, like, they have a chair, they have a motorized chair, but the patient had a stroke and they come around this beat up jazzy, give us a call because the odds are they should be in a chair that has some sort of tilt or some sort of contour back on it. We can probably upgrade what they're working with. So the 5-year shouldn't scare you off in terms of they cannot get something, they could get something. We just need to see what the patient's insurance is, what they have on file. We'll know what we can or cannot qualify them for. Any questions?
What type of diagnoses, or not diagnoses, but I'm thinking like for the speech therapist, for any swallowing issues, like does that qualify for?
It doesn't work in the mobility aspect.
Okay.
Although it's like respiratory, for example,
right.
A lot of times you get a request, the patient needs recline for respiratory. For some reason unbeknownst to anyone, Medicare does not recognize respiratory as a justification for recline. So
okay.
That's part of what
so
we
no
do.
Swallowing, no
respiratory. For respiratory. They may have another issue that we can focus on in terms of the justification to get them their respiratory needs.
Okay.
So that's kind of what we do. Like, if you're not sure what the patient needs, you don't have to know everything. We're not expecting therapists. You guys didn't go to school to figure out how to write wheelchairs. You went to school to figure out how to do PT or OT or speech. So it's our job to figure out how to get the patient what they need. Your job is to identify and say, this patient can really benefit from something more than they're getting. Let's see if we can get them something better than what off-the-shelf product they would have been recommended for. All right? And that's kind of what we're trying to do today. Just try to educate and impress on therapists that your patient can most probably or most likely benefit from something more than off-the-shelf. If you feel like they have any of these sort of concerns of propelling, pressure issues, maintaining their posture and so on. And instead of having to go into that world of trying to provide motorized wheelchairs where it never gets done, you have a lot of work on your end, and the patient's just unhappy when they don't get it. We have a 100% turnaround on power chairs approval rating. If we say the patient's going to qualify, we come in and we get it done. We're not just going to start submitting files that we're not going to get approved on, and we have a really smooth system to really take that job and onus off the therapist. All right, guys? Thanks for your time. Yes?
If the rehab department is recommending a power wheelchair, how would the process go to send a referral to you and
so
see
you
if they
send us the pay
qualify?
sheet. We just check their demographics, their eligibility, make sure that they're insurance. Sometimes you have a patient that they didn't tell me about it, they got a power chair 6 months ago, the provider took it back, we have to check on our end, make sure they're eligible. As soon as they're eligible, we'll say when's the patient going out, we'll schedule time, put them on your schedule for that time that we're coming in, and we'll coordinate that schedule and come in through the entire process with you.
Over here was 2 numbers.
So we really hold your hand through the process.
And then I just had a quick payer source question. I know we talked about it briefly the other day. Medicare Part B's for our long-termers does not cover.
No, not.
So it's really mainly for the subacute.
Correct.
Okay.
So and then on the private insurance side, is every policy is different. So we have to see the policy first. The Medicaid side as well, we have to see what the policy is. But Medicare, if they're straight Medicare primary, that we know is not a problem.
And straight Medicaid, typically.
Straight Medicaid is also not a problem. It's just hard to come by. I mean, once they leave the nursing home, see straight Medicaid in New Jersey, if you find them, send them my way.
But the MLTSS's you can
some yes.
Okay.
All right.
So if the OTs and PTs and actually speech too, if they can kind of think, and I'll put together a potential list.
Do it like that. Well, if we can do, once a month, you say heads up, who's going home the next few weeks. If you have 2, 3 pages, one patient, we'll do it all on the same day. So we'll just line them up 10 o'clock, 11 o'clock, 12, whatever it is, and we'll do like a wheelchair day for us, and you'll have those patients that are in the discharge planning at some point be evaluated at that time.
Okay, cool. Awesome. Thank you.
All right, guys.
Thank you.
Thank you.